Let's move to active inference in the therapy room. Fristonian thought equates psychopathology with a failure of belief updating. Psychiatric disorders are seen as computational disorders of decision-making in the body. In the book Active Inference, Parr et al. Link psychopathology to aberrant prior beliefs and provide a table that describes how the active inference process, based on faulty prior beliefs, can lead to the behaviors that we associate with mental disorder. One example is addiction. Research by Fitzgerald and Schwartenbach connects addictive behaviors with prior beliefs about the likelihood of receiving a promised reward. Low confidence levels in the expectation of reward result in obsessive and compulsive relationships with the substance or activity. Adjusting prior beliefs about the availability of reward could reduce the desperate nature of the hedonistic grasp, such that recovery looks behaviorally more like moderated use of addictive substances and activities, rather than the neuroticism of rigid abstinence or obsessive sublimation. The table also lists psychopathy, connecting belief models about interpersonal behavior with personality disorder. Active inference may work upon faulty prior beliefs about how individuals generally respond to interpersonal behavior. In the studies cited, researchers mapped the degree to which beliefs about self-worth depend on decisions to be charitable versus selfish, and sensitivity to the approval of others, to the emergence of the behavioral traits commonly associated with psychopathy. So how do maladaptive false beliefs come about? The active inference model provides a fascinating theory. In the message passing computations mentioned before, the data in each message passed appears to be encoded with a measure of precision, a likelihood that a correct inference about the system's environment can be drawn from the sensory data. When it comes to cognitive schemata, the precision of a belief is potentiated by neurochemicals. Parr et al. Suggest that the cholinergic system, part of the nervous system that responds to the neurotransmitter acetylcholine, and the serotonergic system, responding to the neurotransmitter serotonin, communicate precision to sensory data sets. These neurotransmitters could potentiate a message such that it is received as having a higher precision than the sensory data suggest. Parr et al. Refer to this as overinterpretation of potentially noisy sensory input. The above aligns with clinical methods that facilitate recovery from interpersonal trauma. In my previous article about Alan Shore's right brain psychotherapy, I discussed modern trends in neuropsychotherapy that highlight the importance of recreating the neurochemical situation of the dynamic mother and child attachment dyad in the therapy room. When the positive social messages of therapy are potentiated with oxytocin, mimicking the neurochemical environment of the early social development of the brain, they become more fixed in the client's brain, in a sense chemically overpowering prior beliefs created by early trauma, and with an overinterpretation of the sensory data associated with the prosociality of the therapy room. In the therapeutic chamber, the counselor is the administrator of free energy by alternately inserting and reducing surprise, in the traditional social sense, across the social synapse. In the artificial environment of the therapy room, they act differently than what the client expects to expect from normative social interaction. The surprise is registered by the client's sensory apparatus, sight, auditory, bodily, processing, at often unconscious levels, disrupting and facilitating emotional and neurochemical rupture and repair. This is the art of creating a safe, but not too safe, therapeutic environment. The client's ability to respond to ever-increasing levels of entropy, free energy, with either spontaneous belief updating or assertive action upon the environment, assertive communication, boundary setting, and self-empowerment, corresponds to what we call mental wellness. In the article Surprise in the Bayesian Brain, Implications for Psychotherapy, Theory and Practice, Jeremy Holmes and Tobias Nolte state that the brain abhors surprise and prescribe a biobehavioral synchrony, similar to Alan Shore's right brain psychotherapy, that connects the client and therapist. Integrating active inference, Holmes and Nolte say this about the client, and I quote, "They are in the grip of perceptual distortion and ingrained prediction errors, driven by the need for a modicum of attachment security, however dysfunctional. In the presence of a modulating, moderating, affect buffering therapist, surprise/energy, unbound becomes tolerable, and when therapeutically scrutinized, extends the repertoire and range of a person's counterfactual realities, i.e. their priors. Reducing prediction error is a complex multi-level and recursive process that reverberates up and down a series of interconnected message-passing hierarchies." End quote. The psychological, cognitive, and organismic influence of the therapist alters the active inference process of the client.